Magadan, thanks to all three of you for your submissions. This is a topic we have discussed many times over, and anybody who's had a child or a sibling or a friend that has experienced bullying, particularly sustained bullying over time, will have no doubt about the link between bullying and student mental health. This submission by yourself, Siobhan, highlights the fact that there are currently no specific guidelines for school or for parents to support autistic students who experience bullying. And even more surprisingly, you stated that there's also no existing research exploring the prevalence of common forms of bullying experienced by autistic students attending Irish schools. So how is that lack of research affecting our ability to protect and support students with autism, as well as parents and schools? And how could that research be funded and supported? That's specifically for autistic children.
Thank you for the question, Deputy. Yes, I suppose that would be an international situation as well. There's very little research having been carried out in terms of the prevalence of bullying with the autistic population in schools, and then even less research in terms of preventative strategies, specifically for that cohort of the population. I suppose how we would like it to be looked at is within the whole education approach, the preventative approach for those, the many, the some and the few. And so whatever proportion of your population falls into the autistic population within your school. I think there's nuances in terms of how those prevention programmes would be developed. Obviously with FUSE, the Anti-Bullying Centre in DCU has a lot of experience for that general population of student, and what they have done every year is check in with the teachers, with the students, about how the material, how the content has worked for them. And I think that would need to be continued in terms of a principle of programme development. The challenge with the autistic population is that because of the communication and the social challenges, that would have to be worked into any kind of prevention or intervention programme that was developed. It can be done, but it does need resourcing, and that's the million-dollar question that you've asked in terms of how would that be resourced. I think a specific piece, a piece of research. We are doing some research in the Anti-Bullying Centre on a European project around the possibility of creating some youth advocates for those affected by disability or autism in our schools. But it's a very small research project, so it definitely needs some further resourcing.
Do you work with the Middletown School of Autism in Armagh? The centre that was set up there, I visited it some years ago after the Good Friday Agreement, and I thought some of the work that they were doing there was very impressive, obviously around autism.
Yeah.
So would an institute like yourself work with Middletown?
I would have a colleague who would be actually a specialist in that area, so maybe he has some links with that, and we can certainly answer that question for you. I'm not familiar with it myself.
Yeah, I think it's very, very important we do.
Yeah.
And it speaks back to, I think it was yourself that said, or one of you said, about 26 years of research. And this is the most thing that I really despair about, because what you're describing here, even in terms of a whole school, whole community approach, I was directly involved myself with Trinity Anti-Bullying Centre with Dr. Stephen Minton. It must be 15, 16 years ago. Why are we still, and I'll separate the autistic one from there because I'm not familiar in terms of, but with school bullying in general, what is happening that the research isn't transforming into implementation, and that sometimes it appears to me that there's silo research being done. So, one institute will be doing this, and, there's almost an industry set up around bullying and mental health. I wouldn't say almost an industry, there is an industry. There's huge amounts of money being spent across the board over the last 3 decades on it. And I just wonder, and maybe this is the question I'd put to both of you in particular, I'll talk to Sarah maybe in a minute. Is there less bullying in schools now than there was before this started 3 decades ago? Are we really making an impact when we see some of the figures that are still coming out in terms of the number of children who are experiencing bullying behaviour in schools? So
I might come in on your particular point about Stephen Minton's work and the Mayo community example that you gave.
Yeah.
I think that was pioneering research at the time. I think the whole notion of community-based bullying research is underdeveloped internationally. It is certainly, I think, a huge area as well. It's a huge area in terms of importance, but it has not been given the policy focus or the research focus in the international research community that it deserves. I think you could extend it further when you're looking at, at the notion of, say, community spaces. How can we create community spaces for well-being, for cooperation, to, undo, conflict between different ethnic groups? How do you create these spaces of cooperation? I think that speaks to the new children's strategic policy framework as well, the new national children's strategy, how we create those spaces. And I think it's something where we really need to rethink how we do this for the future. For example, we have a focus on playgrounds, for the very young children, but where are the spaces for the later primary children to play in, cooperate in? Where are the spaces for the early secondary school students to do the same, and then the older secondary school students? So we need a spatial strategy that includes a community level, and of course COVID has also invited an acceleration of focus on issues such as access to nature. So this would include spaces for well-being where conflict can be overcome through cooperation, and this includes at a school-based level, such as school gardens. It's a very simple space again. We have, with our own centre, Education Advantage Centre, studies where we're seeing the impact of school gardens on the well-being and the cooperation skills, the social and emotional development of our children and young people. So again, it's about how we create our spaces in our school system that foster cooperation, collaboration. So it's like so the first stage would be to develop the social and emotional competences of our young people. And bullying is in one way a failure of communication of our young people because they've not been given the spaces to communicate and the spaces to collaborate in. Would be
and that was in that model, in Stephen Minton's model, it did look at international best practice as well, and it did look at a whole community approach. So the GA clubs, the soccer clubs, and everybody else within the community. So there was an evidence base there. So I suppose what I'm saying is this evidence is presented and recommendations are made, and then it falls at that, and then someone decides to do another piece of research and another piece of research, and we're 2 decades later, and we still don't have the impact that we've had. Who follows up this research afterwards to see, how it's been implemented or the outcomes from it? Sorry,
Debbie, I'd just like to respond to your initial question in terms of what we focus on when we're measuring, and I can understand the frustration in terms of prevalence, and are we seeing any decrease in prevalence? I suppose what we'd be advocating for is that we look at a school climate survey, we look at those things across the school, those things that create, a caring, a safe climate. And because if we focus on prevalence only, we run the risk of exactly what you're talking about, feeling why is it not having more effectiveness? Measuring the self-efficacy, we see huge improvements in terms of the students' own confidence levels and ability to recognise bullying, to intervene as bystanders. And also, very interestingly, this year, the Anti-Bullying Centre have looked at how teachers perceive their own capacity, though, so their self-efficacy, they feel more confident after delivering the FUSE programme. So I think they're really important factors. In terms of implementation, as somebody who was involved in implementing programmes in the community for a very long time, I would also share sometimes the frustration between we talk about evidence-based practice, why doesn't it, hit the ground? I think some of that is around context, because some of the evidence that we have is not in the same context that we implement it in, and that's why we would be advocating for very much an implementation that takes account of the school and the community around it. How can that be facilitated on the ground?
Well, yeah, exactly. And how can we scale up the models, the pilot programs that are being used? Sarah, I'm very interested in your. Can I go ahead?
Yeah, okay.
I'm very interested in your EHMP's model and how that might work. And from my own experience, I think it's something that could work very effectively here. So how are you measuring that, or how are you going to measure it in terms of impact as we go along, and maybe just to give you an opportunity to explain more about this specific model.
Yeah, so the EMHPs are trained in their low intensity interventions, which are based around the principles of CBT. So we have things such as behavioural activation, behavioural experiments, cognitive restructuring. And as part of that, we have an organisation who provide us with routine outcome measures, which are done pre and post and during the intervention with our young people. And it's from that we measure and report onto our national team. So we're looking at the paired outcomes through the routine outcome measures. So one of the key ones for us is our revised anxiety and depression scale for children, which is used nationally. So you can compare the interventions across the board. We also complete our own audits within the schools that we're working in, and that is one of the interventions that the EMHPs do as part of their training. And from that, we then can help work with the school community on where their gaps are and support them in meeting those needs. The whole model is an evidence-based model, and that's part of the rationale behind that. So hopefully that answers it a little bit.
Yeah, it does. And I particularly like, because one of the biggest barriers we have here, and I talked to yourself again about the Paul, around the partnership model and stuff, is that we don't have the sufficient workforce there, skilled workforce. So we can say, right, this looks like a really good model here that could work in a community, and then we fall short in terms of those we need to implement it, whether it be counsellors or other clinical practitioners. So you say there that you're developing a new and skilled workforce from people who may have traditionally entered the healthcare work. So did you have the same problem as we had here in terms of not having the suitably qualified personnel available to implement? And is this your answer to that? And then Paul, I might ask you if it would work here. Go on.
It's certainly one of the reasons. So we obviously have our traditional CAM services across the country, which have your core professions, which take 3 years plus to train. So kind of nursing, occupational therapy, social workers, counsellors, psychologists, etc. And the idea behind this model is that the EMHPs, it's a year-long course, but it's an on-the-job training. But actually, the people working in the schools who can complete these skills can come from any kind of background who are interested in learning those therapeutic techniques. Because they're so heavily supervised by people with additional qualifications, we really work to build that workforce. So for example, some of our EMHPs have been ex-teachers. We've got ex-TAs, we've got people who've run fear of flying courses, for example, with airlines who were made redundant in the pandemic. So we've got and we've also got people like psychology graduates or previous assistant psychologists who actually want to go on and get a recognised qualification. And they are limited to what they can offer, so they can only offer that low intensity CBT interventions and the whole school approach. But what that does is it then frees up our colleagues in the other services, such as our core CAM services, to be able to focus on those young people with the additional, more specialised needs. So it enables it's a way of managing the demand, capacity and demand, really, to manage that. So the EMHP model is that early help and prevention, and then if you need more specialist support, then we can escalate up through our kind of more core CAMS pathways.
Yeah, which seems a very sensible approach. And maybe Paul, for just yourself and Siobhan, two just questions around that. If that could work here, in terms of how it's done, and what role would further and higher education play in ensuring that we develop that workforce as well?
I'd raise a number of questions about the model. I think the days when, in one way, this UK model, the Dorset model, is playing catch up with many other countries in Europe who've had multidisciplinary teams for decades. Are
you talking about ourselves having multidisciplinary teams, Paul?
I've been an advocate for over 20 years for multidisciplinary teams.
Yeah, but we don't have them here.
We've designed one, say, for example, in Ballyfermot, which was a multidisciplinary team family scope 20 years ago to design that. And what I would say around this is that there are certain key professions. You have to be very clear about what you want each person on the team to achieve. And we've also, advocated for speech and language therapists with ministers, and advised, and occupational therapists in schools, and we know we have those pilots going there. I've done a review for the European Commission on this area. I've done 2 reviews for them around these issues. At a previous meeting with the committee here, I argued that we need to look at sort of Danish models and Dutch models. That in Denmark you have a multidisciplinary team for every school. So Ireland's been playing catch up in this area for decades, but also the UK has been playing catch up now. And so I think when you look particularly at the models that's being looked at here from Dorset, it would be unremarkable, to be blunt, in a European context. It really depends on which professions you want in your team to achieve which objectives. I don't also accept that there's a shortage of specialist emotional counsellors in the Irish system. Okay, we have these. I've also, in our longer submission, we've quoted the chair, Angie O'Brien, the chair of the Irish Association for Creative Arts Therapists, to say that there's easily capacity to fill those roles. So in terms of the direct delivery, one-to-one support services, we can fill those in a national pilot.
So why do we, sorry Paul, because this is an interesting thing to tease out, so why do we have such long waiting lists for CAMs? Or from what we hear from schools is that, we refer somebody, and there's 2 things with it. First the waiting list for the child to be seen, and then the regularity for that child then to be seen in terms of the consistency, and also so just even in those 2 things of how long children have to wait, and no feedback then from, if there is a multidisciplinary team in place, or they go away to have their meeting, there's no feedback to the schools in it, so there's no loop, so the child is not at the centre, and the child's family is not, it doesn't appear to be at the centre of what is.
Okay, there's a few points to distinguish here. So one is that the whole area of trauma, adverse childhood experiences, pertains also to the preclinical stage. So the focus for the specialist support services in schools, the counsellors, the special emotional counsellors, it was focusing on the preclinical level. So to stop problems early before they mushroom. Obviously that includes bullying issues where you have children internalising self-hate processes. You want to stop this internalisation process early and quickly. So this is all the preclinical level. So there we have the support, we can have the staff to get that off the ground quickly in the Minister's initiative. So we don't need to train in external people who've been in other backgrounds for that particular part. In terms of then at the end of our submission and in our previous submissions from our centre, and we've noted the public health model of differentiated need. I think Siobhan has referred to it also as the all, the some, and the few. So there's different levels of prevention there. So you have the universal level, the select prevention for moderate risk, group-based interventions. And then you have the indicated prevention, chronic need, complex needs, one-to-one supports. The key gap in the Irish system is the indicated prevention level, the one-to-one supports. Much of the approaches that from NHS Dorset that are advocating, NEPS has been doing, and the wellbeing framework looks at a lot of that type of group work and universal approaches already in the wellbeing framework. So there'd be a huge duplication of function and role if we were to just transport this model into the Irish system. Now having said that, I would be arguing that there's a clear distinction to be made between phase 1 of the specialist pilot in primary schools and as we're advocating for secondary schools. Phase 1 would be you put the specialist counsellors in for the one-to-one supports. You have the other group-based levels in the schools already, and then phase 2 would then ask, I think, the important question: what other additional professionals do we need? So, for example, if we want to move towards a family and community-based model, as I think Siobhan has adverted to, then we need to be looking at, family support workers in that team model, social care outreach workers to the homes, nurses perhaps. So it's a second layer but we need to be really clear on which professions we want and why. Because let's be clear, multidisciplinary teams are expensive, all right? So So you need to make sure that each member of the team has a very clear function, and they also take time to develop. Our report for the European Commission with Professor Anne Edwards of Oxford noted, I think, two other issues. One is that you need is that you can't just transport something from one context to another. We have an existing system of services here that we need to work with and around, and also that you need.
So do you mean, Paul, that we need to tweak the system that's already there, that is failing so many children as we are today?
Okay,
because there is a lot of children, and I think we would all have to agree with that. There's a lot of children being failed in terms of intervention, prevention, at school level in young children.
Well, let's be clear that the mental health practitioners that would be a year-long course from other backgrounds will not replace the CAMS clinical specialists.
No,
okay?
I think we're all clear on that.
Yeah,
but in terms of getting at an early stage, so when, and that's the key to this, even in terms of resource allocation, of getting at a very early stage, and then you don't have to have the other interventions as you go along. And I know we have the likes of Jigsaw, and we have Mindspace and Mayo, and that certainly serve a purpose there. But in terms of being able to really meet the need that's there, are you saying that that the models that we have here work and that they just need to be adjusted? Or that
I think there's certainly scope for dialogue with NEPS and the wellbeing framework around the universal level and the moderate risk group-based approach to see is they're learning from models such as Dorset or other models and programmes. But you know, NEPS would argue that I'm sure that they're looking at the various evidence of international practice. But again, to be clear, that a programme-based approach is much more the universal and the group-based moderate risk group, the selective prevention. So it's not just universal and targeted, it's universal, group-based, moderate risk approaches, and then the chronic need, individual, complex, one-to-one supports. My argument to this committee, you know, and this is my third presentation here, is that it's the one-to-one focused support is our major system gap in Irish schools, and that's what the Minister has now sought to address. I know the Minister in her initiative also states that this new initiative will be separate from NEPS. So it's a clear focus on the indicated prevention level, one-to-one specialist emotional counselling supports in school, not referred out from that.
So can I just tease that out again? So the counsellor would be actually in the school?
Yes, okay. Yes, in the model proposed by the Minister for primary school.
So that would see that each primary school would have a counsellor attached to it.
For the national pilot, and what I've just proposed earlier is that you would ideally look to move towards that over time. The national pilot would be proposing one counsellor between two schools, two locally adjacent schools, so to minimise travelling, but they're embedded as staff in those schools for both structured appointments and flexible, crisis management. So as a child, presents on the day with particular issues that may arise in class. So what you would have is based in the school. Sure, it would be school-based, and that's what we need also in the secondary schools. We do not have, for trauma and adverse child experience, we do not have this in the school system. And the point that we've made in our submissions is that this is routine in many international contexts. It has been for years. Our own report for the European Commission on early school leaving highlighted as well that in many European countries, this is again embedded as a feature of their system for a long time, and we have always had that system gap.
Has there costings been done on that, Paul?
The costing that was presented for a national pilot by the Child Ombudsman that was in the annex to the bullying report was 10 million for a national pilot, 5 million which is now for primary, 5 million for post-primary, and that 5 million has now been given by the Minister for
But when you say a national pilot, if you were to have the situation then where you have a counsellor for every two schools, how much would that cost?
The Ombudsman, gave some figures around that in terms of if you're looking at in terms of the amount of money on a pay scale, on the scales for therapists, that can range depending on the seniority of the position. But it is a relatively modest fee for the kind of gains and benefits you can get from this, from a whole range of policy perspectives, from the mental health post-pandemic perspective, from the bullying prevention perspective, from the LGBTI plus identity issues that may arise in the school where they want support around some of those issues too. to, from children, care leavers as well, children in care who may be accessing our systems. There are so many vulnerable groups here who could avail of this.
Oh, I completely think that it is the right way to go. But what workforce planning do we have to do at this point? We don't have enough counsellors. You know, I know we don't have enough counsellors to meet the need that's there. So have we anywhere quantified the number of counsellors that we would need and what we would need to do right at this point in terms of next September, say, an intake to have counsellors fully trained?
Well, my understanding, and I've talked, I think others have also noted this as well, is that there will be enough counsellors on the ground to be in large urban centres, in large numbers, in large urban school. When I say urban centres, I mean in the large cities, the schools in the large cities, and in every county in Ireland, we would have enough capacity. The issue is not the shortage.
So that we have enough counsellors as it is at the moment. That's interesting. You're saying we have enough sufficient number of counsellors.
And they're just not. They're part-time. They're ad hoc. They've been in and out of Irish schools for several decades, but they've never been embedded in the system. And what it then brings is that you then don't have the relationship building. They're brought in on a short-term contract. They foster a relation with the children, say, for example, over bereavement, and then they disappear.
And thank you for that. I understand, but that would contradict, I suppose, that why if somebody's looking for a counselling service tomorrow in Mayo, that it may take months for them to get that counselling service. So if we have enough counsellors there, it would almost. I'm only trying to join the dots.
I'll come in at that point as well, because I'm actually quite interested, because two were on the same train of thought. But in if you want, no problem. But Paul, you said there's no shortage of counsellors, yet I was talking to a constituent just through for me that the earliest session that they can get for counselling is February of next year, right? So you said there's no shortage of counsellors. Are you going to take a lot of these counsellors out of the services that they are already providing counselling to, if you get me where I'm coming from, right? Into kind of 9 to 5, where they are maybe working the evenings, night times, volunteers and everything like that. Are we going to put these other voluntary organisations who work on like a donation type, and look, they're in my constituency and no doubt, Deputy, they're in your constituency, they do a fantastic job. Are you taking them, draining them from that?
Now, I've had extensive dialogue with a range of different counsellors, on this issue, different groups. It's clear that they're very enthusiastic about the school-based model. They don't see this as taking from their other work. A lot of them are working part-time in short-term contracts here and there. As I said, I've quoted Angie O'Brien, the chair of the Irish Association of Creative Art Therapists, who stated on the record in a submission that there is enough in the system. So I think it's. Just one other advantage, I think, of the area-based approach, I think, for counsellors is that it can also. As I said, it can avoid the duplication, perhaps. If you can get a family dimension also in this as well, so you can see siblings in different schools there may be similar issues coming up. That you can have, if you've got a team there of counsellors with a head of team, you can build that coherence at an area-based level and a family-based level, which I think would be an important dimension here. And the area partnerships and the ABCs already do this a little bit here and there, but I think they are ripe for expansion. They both have stated in our submission that they want to expand in this area.